gonna have a test tomorrow.
No,
Yeah, tomorrow.
We
Yeah.
are.
Just spleen.
Just spleen.
Yeah.
It's a smaller chapter.
Without homework, just test.
Yeah, there's no
Yeah,
homework.
it's good.
I mean, if I give homework, that's because I want you guys to get points. It's not because because I feel like it'll help you guys out. But I am about to do an assignment in class. So, but we'll do that at the end if we have time. So yeah, we'll probably aim to have the test tomorrow, and then we'll go over it on Wednesday, and you guys will probably start the lecture for kidney on Wednesday. And then of course that test won't be until sometime next week. Okay? Ms. Shepherd, I won't even be here. I won't be here next week. Really all of next week, but I may come back on Thursday. If Ms. Shepherd finishes early and I have to lecture on Thursday, I'll be back and I will lecture gallbladder. Okay. And also another thing, this is my first time. If you guys have any suggestions or anything, I'm open to anything. If you don't want to say anything in class, you can come up to me one-on-one, I'm up for any ideas. Because like I said, all this is new to me. Everybody learns a different way, so I'm trying to figure things out. So if you guys have any suggestions, feel free to come to me. Don't be...
Any complaint too?
That too. Hey, that's how I learn. If you have any complaints and I'm not doing something right, let me know. Because, this is a whole learning experience for me as well. So any kind of idea will help me out, will help you guys out. So just, feel free to come up to me. Okay? Alright, so we're gonna continue talking about spleen. What is the normal measurement for spleen?
Yeah.
Sorry, because you guys are paying, oh. Okay, I was gonna say you guys are paying attention whenever I was talking about spleen.
But that would be the width, right?
The length.
That's
Length. In longitudinal, the length is 12.
And then the width would be like 4 centimeters.
Yes, 4, 5. I think the book uses 5. Let's see. Is it saying the transverse 4?
4.
Yeah. But mainly know the length. Length is more important because that's what they use to determine splenomegaly.
That's what we were using just like in the light.
Okay, so we're still going to talk about embryo. There's two types of pulps. There's white pulp and red pulp. The white pulp, it has a length that's related to the nodules. That's called the I can't say that. The one that's in there. Something like that. So that contains lymphocytes and macrophages. Also marginal zone, which are rich in macrophages and lymphoid follicles. This plays an important role in the normal immune response to infection. And then you have the red pulp, which is 80% of the spleen, consists of 80% of the spleen, and it's separated from the white pulp by the marginal zone. It's primarily made up of tissue known as the cords. And what is the function of red pulp, which is important? It removes old, damaged, or dead red blood cells. So if the blood cell is not in its shape, in the biconcave shape, they'll get rid of that. After 120 days, once it's circulating, it gets rid of that as well. It also has storage of red blood cells. So right here, if you look at this is the histology or the tissue of the spleen. All of this right here is the red pulp, which it is 80% of the spleen. And then here's the white pulp. So white pulp, and it's separated by the marginal. Okay. So the spleen is highly vascular. The arterial blood is from the splenic artery. Do you guys remember what it branches off of?
Yeah. Celiac.
What does the celiac axis come off of?
Splenic artery.
So, on the test I can ask you, what is the blood supply of the spleen? And I can have a splenic artery, celiac axis, aorta, any of those. Is it the first branch, second branch, third branch?
The first.
First branch. So the splenic artery courses along the superior pancreatic border. This is what we had talked about. Superior is the correct term that's used for the location of the artery. So it divides into superior and inferior terminal branches before entering the hilum. And then within the hilum, the splenic artery divides into 6 or more segmental branches before it separates into little arterioles into the spleen. They may be visible as small echogenic lines coursing through the parenchyma. And the only way you can tell if it's a vessel is what?
The blood supply.
Color. So you turn on the, turn on the color box, and if there's color, then you know it's a vessel. If it's not, then it's something else. Okay? So the intrasplenic arterial branches, they don't anastomose, meaning they don't connect or they nor communicate to create collateral flow. And without the collateral flow or connecting, you have increased risk for infarction. The small segmental artery branches, it provides blood to white pulp before flowing into the venous sinusoids. So the splenic vein is joined by the inferior mesenteric vein, and which way does it travel? Where is it located in regard to the pancreas?
Superior.
Posterior.
Oh.
Posterior to the neck or tail?
Yes.
Tail of the pancreas. And it joins with SMB to form what? Portal vein. So you see how everything's kind of coming together?
Yeah.
It's kind of same thing. So it unites with SMB posterior to the neck. So remember, at the neck is where it joins with SMB, okay? To form the hepatic portal vein. So this is just showing that here's this splenic artery, which is superior to your pancreas, would be like right here. So it's superior to it. Splenic artery is a branch off the celiac trunk. And you have the splenic vein, which unites with inferior mesenteric vein, which forms with SMB to form portal vein. Okay. Which anatomy forms the anterior border of the spleen? Stomach. Good. Anterior border of the spleen. So it's located anterior.
Stomach.
What, stomach?
Yeah.
No, stomach is anterior.
Oh. Okay.
Posterior would be your
Kidney.
kidney.
The left.
Left kidney.
Yes, left kidney, correct. Which pathology is at increased risk of developing because intrasplenic arteries do not anastomose or communicate to create the collateral flow? Infarction. Okay. Alright. Now we're just gonna talk about the normal variants, sometimes that we may see. We have polysplenia. Poly means what?
Many.
Many.
Right. It's very rare. The cause, we're not sure, but it's associated with other different anomalies, such as malrotation, IVC anomalies, biliary atresia, any of those. But they don't really go much into detail about this. Aplasia, which is also rare. A means without. So something during the normal embryogenesis, something doesn't happen, so they don't have a spleen. So, leading to congenital absence of the spleen. And it's indicated by absence of splenic tissue. So if the patient comes in maybe for left upper quadrant pain and you're scanning it, that's when they'll notice that they don't even have a spleen. And the patient may not even know because we can live without our spleen. We don't have to have our spleen to function. Which is also rare, but a lot of times, if you're scanning in this area and you don't see the spleen, you always have to check elsewhere because it could be somewhere else. Just because it's not, normally it's supposed to be here, but if it's not here, you check usually maybe like in the pelvic area. Same thing with kidney. Kidney, it's supposed to be here, but a lot of time if they've had a kidney transplant, it won't be in the location, it'll be in the pelvic area. Or sometimes that's what they were born with. Because one time I had a patient, I couldn't find it. I spent 15-20 minutes. I was kind of new, I was like, how can I not find the kidney? And I was like, I don't wanna go ask a tech, and then her just put the probe down and be like, oh, look. So I just started wandering around and it was in the pelvic area. But it's been about 20-25 minutes.
But that's normal?
It happens, you see it, because if they've had a kidney transplant, it is. Or a lot of times they may only have one kidney, and they may not even know. So you're still looking for it. Because you don't wanna say that they don't have it without being definite. But then you would just document. So let's just say you're looking at the kidney, you're looking for left kidney, you don't see it, you just put left kidney area, document, and then put left pelvic area and document showing that you looked over there and you didn't see anything. Just to cover your behind. So splenic hypoplasia is defined as reduced splenic mass and or function resulting from defective development. Diagnosis may be incidental because of abdominal symptoms such as left upper quadrant pain or epigastric pain or anything. The one that's more common is accessory spleen. It's a common variant seen in approximately 10 to 30% of the population. It's a congenital anomaly in which the splenic tissue, it separates from the main splenic body, and it's ectopic to the location, meaning it's not with it, it's located elsewhere, but usually you see it at the hilum of the spleen. Most are very small, they measure approximately 2 centimeters. Okay. So approximately 75% are near the splenic hilum, and hilum is where you will see all the vessels going in. Approximately 20% are located within the pancreatic tail. It could be mistaken for a hypervascular pancreatic tumor. 5% occur along the artery, the gastrosplenic, or splenocholic gastrocolic ligament. With this, so of course, whenever you see it, you would always just turn on color to make sure to see if there's any flow. But with the accessory spleen, the echo texture is going to be the same as the spleen. Which, I have a picture, I'll show you guys. So they present as round, mildly echogenic, and homogeneous with posterior enhancement. Following splenectomy, accessory spleen may assume function and size of removed organ. So accessory spleens, they rarely undergo torsion or infarction, anything that's associated with left upper quadrant pain, because it doesn't have any type of ligaments or anything attached to it, so it's not prone for any type of infarction. In most cases, there are no clinical consequences. So this right here is the spleen. And you see this round hypocoag area close to the hilum. This is the accessory spleen. And you'll probably see a lot of this. I've seen it quite a few times. And then this is the longitudinal spleen with the accessory. Okay. Make sure you guys know how images look in transverse and in longitudinal. Be able to identify it. If I just have this image, be able to tell me if it's transverse or longitudinal, and vice versa. Okay?
It's transverse.
Yeah, this one is transverse.
That's
Oh, yeah.
Usually whenever you do transverse, it's located on the left of the screen. When it's long, it's on the right side, but I mean, it's still,
The accessory is the tissue, who transfer from the spleen to somewhere?
it could be somewhere else, yes.
Yeah.
But 75% of the time, it's located by the hilum of the spleen, which is right here. This is very common.
So it's part from spleen?
It's, yeah. Mm-hmm. Huh? Yeah, this is long spleen. And I guess, I mean, the way, whenever you do transverse, like the spleen will be on the left side of the screen, which this is the right side of the screen, left side. So this is transverse. When it's long, you'll see it on the right side of the screen. I should remember that way. But of course, whenever you start scanning, you'll get a feel of it and be able to tell which one is trans and long.
And the long is easier.
Hmm.
The long is easier to find it than the trans. We did it today.
It's different with everybody.
Yeah.
There's no telling. Spleen, I think that's one of the ones that I had a hard time scanning. The spleen.
Yeah.
Just because of the location and the ribs.
Behind the ribs, yeah.
And even like a lot of times if the patient is supine, it'll be hard. I always have to have the patient the right lateral decubitus with the arm up and then scan here.
But you get order from doctor ultrasound for spleen, scan spleen, or CT scan more.
If it's a complete abdomen,
Yeah.
you always do spleen.
Yeah.
You're never gonna get an order just for spleen.
CT
Spleen is part of the abdomen ultrasound. So you do that regardless of any symptoms
And
or
which
not.
the abnormality except just you see splenomegaly, that's it. Or you
A
can
lot of times. And a lot of times if a patient has problems with their liver, they'll have spleen problem as well. And mainly splenomegaly is what you'll see. Okay. So now we have wandering ectopic spleen. Wandering meaning it's somewhere
different size.
somewhere else.
Yeah.
It's not where it's supposed to be. So this usually happens when there's incomplete fusion of the dorsal mesentery with the posterior peritoneum. When the patient doesn't have a history of splenectomy, what does splenectomy mean?
Remove spleen.
And splenic tissue isn't visualized in the normal anatomic location. The sonographer should check the left side from the thorax to the pelvis for an ectopic or wandering spleen. So wandering spleen is defined when the spleen migrates from the normal left upper quadrant position to other abdomen or pelvic location. Where else is the spleen located? What else can I use? Left upper quadrant or what? What were the 9 different quadrants?
Let's
So it can go the bottom one.
Left what?
let's
Left hypochondrium. That's another one that
Yeah.
I can use. So this occurs when there's a loss or weakening of supporting ligaments. So if there's loss or weakening of ligaments, can you have torsion? Because there's ligaments, so what can happen to the ligaments? They can
Yeah.
twist, so you can have torsion.
Yeah.
With accessory spleen, can you have torsion? Because there's no ligaments or anything. Make sense?
Yeah, yeah, yeah.
Can you repeat again?
ما تقدرش تتحرك تابت.
When?
With the wandering spleen,
Yeah.
you have ligaments that are attached to it, but the ligaments are weak. So when they're weak, they can easily twist, and when they twist, you can have torsion, meaning you lose blood supply to that organ. When you lose blood supply, they have to remove it. Whereas with the accessory spleen, it's just a tissue, so you cannot have torsion with accessory spleen.
So maybe some patient has ectopic spleen and diagnostic long time like.
They could, or
Wow.
maybe not. They only, I mean, maybe if they had a CT or something, then they would be like, okay, the patient has ectopic. But if the patient had never been to the doctors and stuff, they might not have been
He's
diagnosed.
normally
They might not
no
even
symptoms, no
know.
signs.
Especially if, like, it's an elderly patient, because if you think about it, when they were born, a lot of times they didn't do ultrasounds.
So in the after delivery, like in the neonate, no ultrasound,
Unless if it's required. If something was wrong with the baby,
do it.
then. But even if, you know, if an elderly patient comes in, they may not even know because when they were born or
At their time.
at
yeah.
their time,
Mhm.
a lot of people didn't do ultrasounds then.
Yeah.
Now we do. Now when you know, when the mother is pregnant, they do so many ultrasounds. So if there is anything, they'll know about it.
For the baby.
So missing is spleen, it has any indication? How do we know that there's something wrong with the spleen?
Well, you can live without your spleen.
Exactly, that's what I want like to
Yeah.
ask for, yeah.
So not
if-
necessarily unless if they go in for something else
and
and
then
it's
they
an
figure out.
incidental finding.
يعني واحد ممكن يطلع معه سبلين ما غير شمعة يعني.
So wandering ectopic spleen may undergo torsion, causing acute abdominal pain, and contrast enhanced CT is the modality of choice. Yes, we do ultrasounds, but is ultrasound the modality of choice for spleen? No, CT is. Same thing with what? Pancreas. So the preferred treatment is to reposition the spleen in the left upper quadrant location to prevent torsion and to try to preserve the function. Except if there's infarction, meaning where the tissue is already dead and they can't save the spleen, then they'll just remove it. So which splenic variant rarely presents with torsion or infarction?
Wandering spleen.
Is that what everybody said?
No, wandering spleen.
Wandering spleen.
Rarely.
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 Oh, rarely.
Yeah. If it said which one most likely,
Wandering.
wandering. Read the questions.
So rarely.
Yeah. Make sense?
Mhm.
Any questions so far?
So, the accessory, what's the relationship between the accessory and the torsion? The accessory is just a tissue in the front of the spleen.
By the splenic hilum.
Yes.
And it doesn't have any ligaments. It doesn't have any ligaments attached to anything else, so you can't have torsion.
Can't.
Cannot.
Okay.
Whereas with the wandering spleen, you can because you have the ligaments.
Okay. And you asked now, you said rare. So because of rare, you said the answer is accessory.
Right. Because it says
Rare.
rarely.
Not most likely.
But if it said most likely, it's gonna be
Wandering.
I mean, why you said with the torsion, the accessory, what's the relationship between torsion and accessory? There's no anything connected between.
so
Yeah.
there's no torsion with
Yeah.
accessory.
Okay.
Which variant of normal is associated with the high incidence of splenic torsion and infarction?
Wandering.
Wandering.
See.
This is the opposite.
Just read the question. I mean, with the spleen chapter, honestly, it's only so much I can put on there. I've been working on the test. I'm up to 26 questions.
How many do you need?
Pictures or? There's no pictures. And I really don't know what to put for picture unless if I do something from previous exam. And I really want to have more questions. I can do true and false, but I hate true and false. Because it could get confusing, you know? And you can easily miss it. So I'm going to try to get up to 40 questions, but I would love to have 50, so.
So there is no label?
As of now, no. Maybe I can have one image that we're going over that showed the splenic artery vein, the inferior mesenteric, superior mesenteric, the portal vein. This image right here. Oh, the impression, yeah.
Copy this.
You have that
Copy this.
photogenic memory. So just look over this, maybe.
Copy this, guys.
Okay. Make sure you put vein, artery. If it's not there, it's wrong. Okay. The fun stuff, physiology. So what is the function of the spleen? It overlaps those of other body organs, so that's why it's possible to live without a spleen. So post-splenectomy patients, however, experience leukocytosis. They're gonna have decreased circulating iron, decreased immune response, increased presence of defective blood cells, because the spleen does all of this. Spleen is rarely the primary site of disease. It's usually elsewhere, and then the spleen will have some effect because of somewhere else. Okay? It's the largest secondary lymphoid organ of the reticuloendothelial system. Okay? There's some true and false questions here. Okay? Spleen is often involved in inflammatory, hematopoietic, metabolic disorders associated with immune and any type of blood disease. Of course, splenectomy is not the first choice of treatment because there's high risk of post-splenectomy sepsis that's associated with bacterial infection. So they'll try to fix whatever the problem is versus removing the spleen. So the four major functions of the spleen is a reservoir and filter, destruction of red blood cells and microorganisms, erythropoiesis, and defense against disease. So we have the red pulp and the white pulp. The red pulp is dedicated to filtration, and the white pulp is dedicated to adaptive immunity. Anything that has to do with lymph nodes, T cells, B cells, macrophages has to do with white pulp. You have the perifollicular zone, which is between the red and the white pulp, which connects both functions. So, a large number of the red blood cells are stored in the red pulp, and it can be discharged into the splenic system circulation. There's fixed macrophages of the spleen that are active in destruction of the microorganism. I don't know what's the best way to explain this. It's just something I'm gonna have to memorize. So the red blood cells are filtered in the spleen. It has two different types of function. The culling function, which it removes any abnormal or damaged red blood cells. So if it's not in its normal shape, the culling function will remove the red blood cell. Pitting function, that's the red blood cell, it goes through a cycle in our body, and it goes through the cycle for 120 days. After the 120 days, the pitting function is what removes the red blood cell. Okay? Also, iron from hemoglobin is converted to this transport form of ferritin, and then it's routed to the bone marrow, which is later on used. You also have breakdown of erythrocytes, which is important in formation of the bile pigments. Okay. So which one removes any damaged red blood cell?
Colon function.
And which one removes at 120 days?
Pitting function.
Which one is dedicated to filtration?
Red blood cells.
The red pulp. Which one is made up of lymph tissue that's arranged around the splenic arterial?
White pulp.
So another function of the spleen is it produces lymphocytes, also produces plasma cells, which is important for the formation of antibodies, and erythropoiesis in the fetus. So some of the laboratory value that we will look at is the white blood count, which normally, the normal count is 5,000 to 10,000. Leukocytosis means when the count is higher than normal. And any type of inflammation, hemorrhage, carcinoma, or leukemia can cause high blood count. Then you also have leukopenia, which means there's abnormally low levels, so it's gonna be way below the 5,000, because 5 to 10,000 is the normal range. So, it's abnormally low levels of white blood cells. Counts below 1,000, there's increased risk of infection because our body is not able to fight what we have. So you're gonna be prone for infection. And if it's less than 500, you have serious life-threatening infection. Some causes of leukopenia is hypersplenism. What does that mean? What's hyper?
Hi.
Some type of viral infection, leukemia, aplastic anemia, or diabetes. What is leukocytosis? Increase or decrease white blood cell?
Increase.
Leukopenia?
Decrease.
If it's less than 500, is it life-threatening?
Yes.
Yeah.
So they also look at red blood cell count. Erythropenia means decrease, low level, and that could be because of blood loss, Hodgkin's disease, or hemolytic and pernicious anemia. Erythrocytosis means increase in white blood count. And one of the main thing is polycythemia vera, which it causes bone marrow hyperplasia, which in return causes increase in blood volume. So your red blood cell count is going to be increased. Okay?
Is that with the erythrocytosis?
Yes, erythrocytosis.
Increased red blood cell?
Yes. Erythropenia means decrease in cell count. Erythrocytosis means increase. Because leukopenia is decrease in red blood cell count or white blood cell count? White.
White blood.
So the other thing that they look at is the hematocrit. If there's increased levels, it's because of COPD, polycythemia vera, or severe dehydration. Decrease is anemia, leukemia, cirrhosis, and blood loss. Okay. Which term identifies the spleen's activity to remove cells lacking the biconcave shape of normal red blood cells?
Cooling function.
What was that?
Cooling.
Which term describes an abnormally low white blood cell count?
Leuk.
C.
Leukopenia.
What does leukocytosis mean?
Increase.
Increase in what?
White
White
blood
blood
cells.
Any questions?
وين الأسئلة بتاعك يا خالد؟
So, just really quick, take about
كثير يعني. هذا مساعدة؟ والله
Okay, so the normal spleen echogenicity is compared with the liver, and it's equal to or slightly hyperechoic to the kidney when the tissues are evaluated at the same distance from the transducer. So whenever we take images of the spleen, when we do transverse, remember it's, if you look at the image, it's on what side? Left of the screen. And then when we do longitudinal, it's gonna be on the right side of the screen, but when we also do longitudinal, we also take one image where we compare the spleen to the left kidney. And that's to show the echogenicity compared to both, okay? So the splenic parenchyma is homogeneous with low level to mid-level echoes that are usually disrupted only by arteries and veins. Within the splenic hilum, splenic artery and its bifurcations along with the splenic veins are visualized. How can you tell if it's a vein or artery? What do you put on there? So differentiation with these vessels is difficult to see unless if we're doing Doppler. So examining spleen requires creative manipulation of the transducer in patient. The easiest approach to image spleen is to have the patient supine position and place the transducer at left intercostal space. Honestly, I think having the patient right lateral DQ is easier than supine. But of course, you always check in supine, but if the patient is supine, you're gonna be reaching all the way over by leaning over and going more towards posterior of the patient to try to locate the spleen. The patient may be placed in the right lateral decubitus with the left arm raised over the head to separate the ribs and allow for better transducer access. Vary patient respiration to optimize the image window. I've noticed with the spleen, a lot of times when I have the patient take in a deep breath, I won't be able to see the spleen. They have to be breathing normal and you'll be able to see it. So a lot of times the way they're breathing helps you to see the spleen. So don't just automatically have the patient take a deep breath. Oops, sorry. Put your probe there, see what you can see, and then maybe sometimes even having them take in a little breath in, that helps to see. So how to prepare the patient? Really, there's nothing, but a lot of times they will be fasting because if they come in, they'll be coming in for an abdomen ultrasound and they have to be fasting or be NTO, ideally 6 to 8 hours is what we like. So for transducer, which transducer do we use?
2.5 to 5.
Huh? To 5, but which one is that we use in lab?
Curve.
Curves, right. Highest frequency transducer is used to allow for adequate penetration. So for image optimization, make sure even right now whenever you guys are in lab, make sure you mess with your focus, your gain, and your depth to get that good image quality. And even the gain settings, like sometimes just make it a little bit brighter, you can see the tissue a lot better. So try to get used to that now, because if you don't do that now, it's gonna be hard later. Because I know right now we're too busy trying to get the image, and once we see the image, we just wanna hit freeze. But get used to messing with the depth. Don't have all that depth in the posterior where it does you no good. It doesn't give you any information. So you don't need all that depth. And also with your TGC, because sometimes on the screen, it'll be a lot brighter in the near field and darker in the far field. Mess with your TGC and have it all uniform, okay? So the protocol, we get a transverse image of the spleen, and when we do the transverse image, we take one measurement, which you guys will look at that in lab, and then we do longitudinal spleen with and without measurement, and the longitudinal will have 2 measurements, okay? And then that measurement for the longitudinal, it shouldn't be greater than what?
13.
So what are some scanning pitfalls? The patient's left liver lobe, it can extend all the way out to the left side. So sometimes whenever it does that, it can mimic some type of pathology, like a hematoma, because you're gonna see extra tissue there. And you're like, what is this? So make sure you're able to differentiate if it is liver or if it is actually the spleen. Or mistaking a fluid-filled stomach because the stomach is located to what compared to the spleen? Anterior, because it's so close, so you could possibly be looking at the stomach and get it mistaken for something else. For adrenal mass, because of its location, normally we cannot see the adrenal gland unless if there's some type of pathology. And I'll vouch for that. Whenever as a student, we're scanning each other. And, you know, the student, she was just scanning me. My instructor comes around, she's like, RT, do you have anything on your kidneys? I was like, no. She's like, oh, you may want to get it checked out. So I went to the doctor's office. What's the normal blood pressure?
Well,
Well, mine was like 200 over 120. Doctor was like, how are you feeling? I was like, I feel good, I have a little headache. I was like, what? She's like, your blood pressure is really high. Well, long story short, she was worried that I had a massive adrenal gland. And because of the size and the calcification and stuff, they had to remove it. And it was all incidental pain. I mean, I had headaches here and there, but I didn't think much into it because I was like, oh, school stress, home stress, you know, just, and I had gotten into an accident, and because of that, I had headaches and pains, and so I didn't think much into it until, So normally you don't see anything, and it was like right on top of the kidney. And they were able to see it. Yeah. Initially they thought it was pheochromocytoma, which is kind of a tumor. But then once they removed it and they did biopsy, it was just a pseudocyst. But because of where it was located, it was messing with my blood pressure, even my cortisol level was crazy, like, yeah.
Are you better now?
I'm great now. That was 4 years ago? Yeah, I had to take some time off from school because the doctor wanted to do it right away because, my blood pressure, it was just no way of controlling it. Because every time I would go, it would always be high. And now when I go, it's like 110 over 70. So yeah. Okay, so due to normal variations in shape and size, the length is what we usually use to monitor the splenic enlargement, which it should be less than 12 to 13.
That's correct. Is that the same as anterior posterior?
Yes. Long axis greater than 12 or 13 indicates enlargement. And if it's enlarged, it may alter the echogenicity. If it's decreased, it may indicate lymphoma. Increase might be because of myelofibrosis or infection, but of course, ultrasound itself, you're not going to be able to tell for sure. They have to have other imaging done, lab work, and whatnot. So right here is the image of the spleen. Both of these, are they transverse or longitudinal?
That's long.
Long, because it's on the,
Yeah, right.
what is this right here?
Splenic island.
I know.
So most likely these are vessels.
Yeah.
So
Oh, where is the accessory?
it's not here. Everyone doesn't have it,
Oh.
but if they did have it, you'll see it like right over here.
High blood pressure. Yes.
So whenever I was talking about the comparison, this is what we take. The spleen and then the left kidney. And a lot of times if you can't get it in one image, because you know how it's kind of cutting off and this, you can use a dual screen. So on the dual screen, on one side you can have the spleen, and then on the other side have the kidney.
Why is it that?
Why do we always compare, like, the pancreas to the kidney?
Because that tells us if there's anything wrong. Yeah, because sometimes like whatever is decreased, that means with that tissue or with that organ, that's what the issue is. Just remember, every image we take,
Yeah, you have to tell us to do it, but I just never do that.
every image we take, there's a reason why we take the image. The comparison is to compare to see echogenicity should be similar. But like for example, if the kidney is very echogenic, that would tell the radiologist that something is wrong with the patient's kidney. So it's just for, yeah. Okay.
What? Hello?
So with the Doppler, it's helpful in evaluating the vascular and to determine if it is an artery, vein, or if it's some type of pathology. And we don't normally do the Doppler with the normal ultrasound. The doctor has to order it for us to do the Doppler. But of course, if we see something we could always turn on the color just to show that it is vessel, not anything else. Okay?
Keep it simple. Keep it
So
simple.
normal
Keep
splenic
neutral.
artery and vein are similar to abdominal organs. We'll get more into this, but whenever we do the Doppler and stuff is to show like portal hypertension and to show that there's collaterals and thrombosis and aneurysm. That's why we do the Doppler. If there's absence of flow in areas, it's usually because it's an avascular lesion such as a cyst or necrosis. It's not a vessel. So right here, so if you're scanning and you see this, you're like, oh, what is this? And you know, maybe the radiologist can question me. You can show an image where it just shows the vascular. It shows that it's just artery and vein. Okay? But this is normal. And same thing, if they order a Doppler study, then we would just do a Doppler reading of the splenic artery. And it's just showing that there is, you know, splenic arterial flow. What examination is invaluable in illuminating hypoechoic vascular lesions that may be overlooked with grayscale imaging?
Color down.
Color. What is an advantage of including images of the spleen on expiration as part of the sonography examination? What was that?
D.
The doctor requests if you're to be
It would. I would say diagnostic spleen. No, I think we'll move it up. So I think it eliminates shadowing.
Yep.
Yeah. Oh yeah, eliminates
تردد
shadowing.
اليوم يعني؟
Would be.
ده نعمل.
So really quick, I want you guys to take a piece of paper out.
Again.
Make sure